So we're live now. Good morning, everyone. Good morning, Dr. Ume Victor. Thank you once again for having you to finish what we started 2 weeks ago. Dr. Ume took us on abnormalities of fundus, fluorescein, and geography, the principles, the anatomy of the choroid, the retinal pigment epithelium, and the retina vis-a-vis these abnormalities. And he gave us a lot of insight into hypofluorescence as an abnormality on fundus, fluorescein, and geography, and various differential diagnoses. This morning, we will do a short overview and proceed to tell us on hyperfluorescence and other abnormalities that can be found with doing fundus, fluorescein, and geography. Thank you very much, Dr. Ume. You can go ahead.
Thank you, Dr. Nurat. Good morning, everyone, young ophthalmologists, colleagues, senior colleagues available. Thank you for this privilege to lead the discussion on fundus, fluorescein, and geography and the abnormalities. So the last time we were able to cover the basics of what is normal, and then we discussed hypofluorescence. So today we're going to discuss hyperfluorescence, but for the benefit of refreshing our memory on what we said the previous time on the basics, and for the benefit of those that may have been absent for one reason or the other, I'm going to just rush through what normal is and then go straight to hyperfluorescence. So this was the outline. So the basic is still that FFA, for short form, is photographic surveillance of the passage of a fluorescent dye through the retinal and choroidal circulations following an intravenous injection. And from what we said is that this is possible because the dye is intravascular in the normal eye. The dye is 80% bound, but 20% is free, and that 20% is what responds to the appropriate light wave. (465 to 490), and then so it's so because this is possible. The FFA is possible because you expect the dye to be within the vessels. So if they are within the vessels, there's a characteristic fluorescence they should give you. So it's about dye being in the vessels, the blood retinal barriers, which is made up of the endothelium and the RPE, and then the fluorescent property of the dye, then time and pattern. Time is that the dye is meant to be at point A at this time. We said if you inject a dye, it takes between 8 to 12 seconds for the dye to be present in the retinal circulation, and it gets first to the choroids. So around 12 seconds in most older people, 10 seconds in younger people, you should have the dye in the choriocapillaries. And what you have is a background hyperfluorescence in the choriocapillaries, which is possible. But the hyperfluorescence is not that visible because of the RPE that also serves as a barrier, and you just get to see the background hyperfluorescence. Then you start seeing the vascular fluorescence that starts with the artery, the retinal artery that starts filling 1 to 3 seconds after the onset of the background hyperfluorescence. So we talked about that. So from the arteries, we get to the arterioles, you cross to the venous, and you see the veins filling. So that is a sequence, it's a relay. Everything happening in time and in order. Choroid first, with ciliary-retinal artery is present. Then you have the artery, and then you have the capillaries, then you have the vein, then the dye dilutes, and you have a repeat of the sequence, but with a lower intensity. That was what we described. So I described this diagram the last time, but for the benefit of doubt, it's simple. The outermost part is the eye. That's you have the inner limiting membrane. This is the nerve fiber layer. This is the ganglion cell layer. In the nerve fiber layer is where you have the vessels, the large vessels. So we divided the retina into two for the basis of angiography. The inner vascular layer, which is from the inner nuclear layer up, and then the outer avascular, which is from the outer plexiform layer down. So this is where you have your big vessels in the nerve fiber layer. Those are the vessels you see on fundoscopy right away. So this is the ganglion cell layer. This is your nerve fiber layer. Then you come to the outer nuclear. This is the outer plexiform. This is your inner nuclear layer. So all the way down to the RPE. So I mentioned about our time, our phase, the pattern and dilation of time. I've summarized that in the few time I've just spent. So the phases and what we found, I described this the last time, but for normalcy, this is a choroid to arterial phase. The choroidal phase is almost complete here. And how you check is that dye flows from around the disc towards the periphery in the vessels. The choroid takes a patchy feel, but if you look, you will still find that some areas are not filled. See this area, the background hyperfluorescence is not yet there. The macula is usually dark, and we explained why, because of RPE arrangements in the macula. They are taller, they are more columnar, and they have pigments, more pigments. And also the macula is a vascular. All right. So that's for that. So you watch where the timing, you look for the timing. And I said for the basics, you are meant to have a fundus photo of the eye, and you have to have a pre-injection photo with the barriers there without the dye. And then you start taking your fundus photograph. So those three should be there. That's the fundus photo gives you a guide, or if there's hyperfluorescence somewhere, or you note where it is coming from, or in relation to your fundus photo. Okay, so this is the choroid arterial. This is the normal arterial towards the, this is the arteriovenous. It's going beyond the arterial. The arteries are full and the vein has started getting filled up. Laminar flow, that's what we said. Laminar flow first before the full bloom. And if you look at the time, this is around 22 seconds plus. Okay. This is the venous phase. If you look here now, we started with a laminar flow. See the dye stripping some part of the vein. And you see the veins here are not full. See this one. But look at here. It's full here. The vein itself is full. And when you look, you find out that the choroidal hyperfluorescence have started diluting out. So it started emptying out. It's the same dye. It's just a transit. So it's moving from one end to the other. So as it's getting diluted from one part, it's getting concentrated in the other part because it's the same dye. So recirculation phase and everything, I said the late phases will be around 3. It takes 3 to 5 minutes to empty out. In some patients, 10 minutes. So depending on the pathology you have, you capture the first phases and then it's okay, let's wait for the late phase. And you, by the end of the day, will know why you wait, not just you take the first few shots and send the patient away. Because you already have the history of the patient, have a fundus photo, you know what you're expecting, you should know where to look for it. So things like leaks, stainings, pulling of dye, this are in the late phase when you expect that the dye should have exited the retinal circulation. If they are still there, then you know that something abnormal has happened. So we talked about the hypo and the hyper. We've discussed the hypo. So I'm going to jump this and move to the hyper. And we'll still entertain questions for those that maybe you went to check on it after the discussion the last time and now you have questions. would entertain them as well. There are many of us here, so would definitely get a good answer. I assure you that with our shared knowledge. Okay, so this is the right place to start. So we're now in hyperfluorescence. Now, hyperfluorescence means that there is fluorescence in excess of what is expected to be normal. It's in excess of what is expected to be normal, or when it's expected not to be there. So either it's in high in essence or in an abnormal location. It's outside the vessel. Is in a tissue space. It's not meant to be in a tissue space. It's meant to be intravascular. Okay. So the possible causes will be a pre-injection fluorescence, a transmitted fluorescence, abnormal vessel and leakages, and pooling. So time and place are very important in this. When you see the fluorescence, where you see it, okay, and what pattern it gives. So these are the possibilities. Now, for the pre-injection, dye is not yet in the circulation, but your shot, your pre-injection angiographic shot give a hyperfluorescence. So there are two possibilities. It's either a natural, that the tissue has natural fluorescence, or that your films, your filters that are meant to prevent wavelengths, the filter is meant to allow the blue wavelength alone to enter the eye and allow the green wavelength alone to come out of the eye. If the filter is weak, blue and green will pass through the barrier into the eye, and the green will come out uninhibited and will be captured as a form of fluorescence. That's a pseudo fluorescence. So tell you that your filters are weak, and usually filters are changed after 5 years. When you see it, it affects the quality of the angiogram. It's more like it adds some, it dulls it out, and then it's not so clear. You get to know. But the autofluorescence is that some tissues have fluorescent properties, one of which is drusen's and some form of hematomas. They give you the abnormal fluorescence. Okay. Now, the other one is transmitted fluorescence. Is that the capillaris is meant to be, the fluorescence is not meant to be so loud because of the RPE barrier. But if the RPE is thinned out or has some break in RMD, or is so stretched out in some people that are myopic, or it's torn for any reason, you have a window defect. So you'll be seeing the background hyperfluorescence of the choroid too evidently. So you know that there's a problem. Vessels. A vessel could be telangiectatic, or a vessel could leak. The dye comes off, it stains the vessel, it pulls in an area. You see an abnormal vasculature, new blood vessels, and all that. You characterize it, and then you decide, okay, what's going on? So the key is determining the time of the appearance of the hyperfluorescence in relation to when the dye was injected, and then the anatomic location of the hyperfluorescence. So I've talked about this. This is an example. So if you look, what the patient has here is an optic nerve head drusen. It's one of the causes of pseudo-papillary edema. You look and you see that the disc looked raised, indistinct margins, and but if you look at the vessel around, you see that the vessels are well outlined. They don't look compressed, and the retinal nerve fiber layer around it is also normal. So it's a pseudo form. Then this is the pre-injection FFA shot. So it's red free. Okay. So now you see hyperfluorescence around the disc, within the disc. It's the optic nerve head bruising. One of the ways to know is that the vessels are empty. Look at it. The vessels are empty. There are no dye in them. So is it dark? The vessels are dark. Every other place is expected to be dark, but you have a hyperfluorescence from here. So this is optic nerve head drusen. So when you see, you correlate. If there were dye within the vessel already, then you start thinking about something else. Okay. All right. So that's for that. So we'll go to the transmitted fluorescence and we'll see why they are the way they are. Now, it's just that the barrier to limit the fluorescence of the choroid being so evident is torn. So you see the fluorescence of the choroid. So you correlate it with the choroidal fluorescence. So when should it come? That's the simple thing that brings it about to be understood. It comes in early with the region of the choroidal, with the timing of the choroidal fluorescence. Okay. If it's just that way, to fade the way it came, and there will be no change. It's just a defect. So it's just like you're viewing the choroidal fluorescence directly. It comes in early, it fades out. It doesn't change in shape because the window remains the same size. What you're seeing remains the same size. So this is what we have here. This is a typical picture presentation in patients with ARMD and drusens. Okay, this patient has drusens all over the place. And remember that one of the feature, the major feature, one of the classical feature for ARMD is RPE changes. If you don't have RPE changes and you have just drusen, you start thinking of differential. It may not be ARMD. Drusen is part of it, but drusen alone does not define ARMD. It's not the only thing. So this person has geographical atrophy. It has a RPE atrophy with the drusens. Remember the location of the drusens. It's within the RPE basal laminar layer. They are around the same region. So the atrophy makes the patchy hyperfluorescence from the choroids to be visible based on window defect. And then the drusen themselves, they stain. So when you look at this film, the first thing you should be looking at is what is the time. So there's no timing given on this film. So we'll look at the vessels. Okay, so the vessels are empty. It's just one artery that is beginning to show some form of hyperfluorescence. So this tells you that this is around the choroidal phase. So what you have is window defect here. So this is the late film where everything has emptied out. The drusen himself stains and retains dye. So this is just showing you the drusen at the late film. Okay. So now this is clear for everybody to understand. This patient or this diagram just shows you that there has been a full thickness retinal defect involving the macula in this patient. So macular hole. So you see it on the fundus photo. There's a hole here. Then you see I would have just asked more like as an interactive section, which phase of the fundus of the angiogram is this? But I'll show you how to know which phase it is, okay? Now, the vessel, the retina is full. There's some dye causing a laminar flow in the vein, and some of the veins are still empty. So this is an arteriovenous phase, okay? Yes. But if you look here, you see that there's still transmitted hyperfluorescence in the macula, just in the macula, representing the area of defect. you're seeing the choroidal, background choroidal hyperfluorescence. Yeah, okay, so this is it. So the next, so we've talked about window defects. We've talked about pseudo, we've talked about autofluorescence. So the next common place is the vessel. And the vessels are easy to, this part is easy to interpret because the vessels are evidently in front of you. You can see the vessel on your fundus photo. You can see the hyperfluorescence and every other thing that happens. You don't have to guess where is it coming from. You will see it and then you categorize it. So what you have in vessel morphology is either a tortuosity or dilatation. The vessel could be telangiectatic, it could be neovascularization, you could have anastomosis, it could have aneurysms, and it could be tumor vessels, okay? So let's go. Now, this patient has epiretinal membranes causing a dragging of the macula. So this is what we commonly call the macular pucker, okay? Or epiretinal membrane maculopathy. How you know is this? The vessels here are not meant to be scalloped. It's the epiretinal membrane that is dragging them, okay? Yes. So, and there's some form, the way they are dragged, you see the tortuosity of the vessels induced by the membrane. So this is your FF here. This follows the normal pattern of the maculopathy, the pulling here. Now, so which phase is this? That's the question. The arteries are filled up. The arteries are almost empty now, and you're transmitting towards the full venous phase. Okay. Now, what you'll find here is that there's some form of hyperfluorescence that is abnormal, but look at where it is in the third fin. Here. So the vessel here, you have a hyperfluorescence and some form of leak here. So these are abnormal. Okay, look at this other side. It's not this way. The patient has diabetic retinopathy with this membrane pulling, epiretinal membrane. Okay. Now, this one is clearer. In the last, when we discussed hypofluorescence, we had an image from a patient who had branch retinal vein occlusion. Okay. Now, in this now, let's look at this. See the fundus photo. The patient evidently has some form telangiectatic vessels, and then some of the vessels are bridging. Where's my cursor? Okay, now, if you look here, these vessels are abnormal. Now, if you get to the macula, the vessels are bridging themselves. It's from vein to vein. Okay, they are trying to cause a bridging from this end towards this end across this area. Now, this was an ischemic branch retinal vein occlusion, and this is an attempt to jump the ischemic capillary zone. So, but on the FFA, what you see, these dots are microaneurysms. These hyperfluorescence here are from telangiectatic vessels, but there are lots of them here in this patient. Okay, and this is the attempt to bridge from vein to jump the capillaries. So this hyperfluorescence is abnormal. So one of the things that we tend to try to characterize in diabetic retinopathy is to differentiate between dot hemorrhages and microaneurysms. And an FFA will show you. If you remember what we said about hemorrhages, and you remember what we were saying about microaneurysms, hemorrhages will usually give you a block, of the background hyperfluorescence, depending on their location, or vascular fluorescence. So if you have dot hemorrhages, usually in the inner nuclear layer, that area will be hyperfluorescent. Then compared to this is an end of the spectrum. This hyperfluorescent, this is a microaneurysm. So these vessels are telangiectatic. So if you also don't have the time and you want to use the vascular phase to check, the vein is filled up. The vein is full. The vein is in full high fluorescence. So this is most likely your venous phase. Okay. Now, this patient has a lot of microaneurysms and telangiectatic vessels as well, the combination. So these are exudates in the patient. So you have to correlate what you're saying with the film. Okay. Now, see this here. You go all the way and look for what's going on. But this is a combination of telangiectasia and microaneurysm. This is a microaneurysm. It's the dilatation of the vessel around those regions. This is another one. Then the telangiectatic vessels are around here, but most of them are microaneurysm. The dot ends of the hyperfluorescence, the vessels have dilated in those regions. All right. Okay. Now, this is one of the easiest to denote when you have neovascularization. Okay. The key remains the same. You watch out for the timing of the hyperfluorescence in the tissue. The timing is very important. Then the location. Now, this patient has proliferative diabetic retinopathy. These are new vessels all over the place. These are new vessels. Okay. Now, what you have here is more than hyperfluorescence, more than the regular vascular hyperfluorescence. Okay. You have, okay, the simple question I want us to ask ourselves is this: why is it that the vessels that we saw around the disc, we can't really appreciate them so well in this angiogram? The answer is simple. Dye has left intravascular spaces here. So apart from giving abnormal hyperfluorescence, the dyes are no longer within the intravascular spaces. They are outside. So you have extravasation of dye with, so this is, you have a pool of dye and it has stained the tissue. So when it says the neovascular vessels are fragile, they leak easily, this is a leak. Okay, down here too, down here. And you look at the general angle, these regions are dark. The concentration of dye within the vessels have diluted in comparison to the fluorescence you're seeing here. Look at it. These are around your late phase or recirculation phases. And you have leakages here. The dye is meant to be in the vessels and should have diluted at this time, but they leaked out, and intravascular flow cannot clear them out at this time. So you have leakages with neovascularization. Okay. Now, this picture is of a retinal angioma in patient with von Hippel-Lindau disease. If you look at the fundus photo here, you can make out some other things that you have some form of serous detachment here of the macula, and there's evidently a large hole here. But our concentration is on the vascular tumor here. So the question now would be, the tumor has its own vessels. and there's extension of the retinal vessels into the tumor as well. So at this phase, someone already just said which phase we are in now. If you look here, you can know the phase we are in. What you have here is the arterial filling. The veins are yet to fill. You have the background hyperfluorescence from the choroid. So this is the arterial phase. The veins are still empty, but look here. You see patchy hyperfluorescence within the tumor. Now, the next picture is a late phase. There are no dye. The dyes have cleared out in the arteries and in the veins, but there's still dye within the tumor. So this is a vascular tumor. So what you have here is the dye pulls within the tumor and give you an abnormal hyperfluorescence. Okay, so that's for this. So the timing is important. The timing is important. The timing of the events. If you don't see the time and everything is assumed to be normal, you check the vessels, check choroidal hyperfluorescence, check the arterial, check the venous, and find out what time is this or what time is it meant to be. And then remember the late phase. That's the phase that most persons don't get to look at. The late phase, the dye should have diluted and should be out. And it should be, if it's anywhere, it should be intravascular. If it's outside the vessel, then wherever it is, it's a leakage or a pulling inside spaces, leakage on the retinal tissue. Okay. All right. So I'll move to the next one. Okay, so this is obvious. This is an AV malformation. So the circulation goes from, there's a connection, direct connection between the artery and the vein. The smaller vessel is the artery, the larger vessel is the vein. Connection here, and when you do your FFA, you see it's delineated. So this gives you an abnormal hyperfluorescence as well. So, okay. In talking now, I've mentioned about leakages. The key is simple. Dye is meant to be absent in the retina at this time, or the vessel is meant to be intact. So the dye is not meant to be on the retinal surface. It's meant to be within the vessels. So if the dye is outside the vessels or outside the barriers, two barriers, RP barrier and endothelial barrier, it means that it has leaked out. Okay, and you most time want to check after dye is meant to be absent in the retina. So 10 to 15 minutes after injection of dye. So what you see is what you characterize. However, there's some part of the retina that some form of late extravascular hyperfluorescence is normal. If you have around the disc margin, the choriocapillaries around the disc margin can give you a hyperfluorescence. Okay, you could have some hyperfluorescence around the lamina cribosa here. In the morning, you have fenestrations and you're seeing dyes from the choroid around the area. Now, if you have an ROPE that terminates away from the disc margin, it means that you have a patch of choroidal tissue that is visible between the disc margin and the start of the RPE. You definitely see a crescent of hyperfluorescence. Okay. Okay. So when the RPE is so lightly pigmented and thin that you may see the staining of the choroidal tissue. So when you see some patients that have high myopia, and you see that you have diffuse chororetinal atrophy, And some persons, even when they have healthy tissue, if you look through, you can see the sclera show. That sclera can be stained at the end of the angiogram. It's just that the dye in the choriocapillaries stain that area. These are considered to be normal in this area, but we'll see the abnormal ones now. So always try to find out what is happening and why it is happening. That's one of the basic ways of knowing what's going on. So I'll use this diagram to explain what's going on here. And most of us would have made the diagnosis in our mind. So this line here is meant to represent the Brooks membrane. Okay. These cells with brown dots is the RPA. So the Brooks membrane, I've explained to us before that the Brooks membrane is not impermeable to fluorescein. It's permeable to fluorescein, but the RPE is impermeable to fluorescein in its healthy state. So here there's an obvious defect in the Brooks membrane. Okay, across the defects, you have, these are meant to be choriocapillaries. You have some form of new vascularization in here, and then some bleeds here that have lifted the RPE up, and you have both a sub RPE and a sub retinal accumulation of blood or new vessels. Yeah. So this is what it looks like in this patient. So you're seeing that, oh, they are bleeds, they are new vascularization, and this is your late film. Late film because the vessels have emptied out. But I told you about something that is normal. You have a crescentic patch of hyperfluorescence around the disc. Okay, this is normal. But see the abnormality here. So you have this hollow or halo-like hyperfluorescence around the macula, the central part of which is hypofluorescence. So you describe, okay, there's a shoe-shaped hollow-like hyperfluorescence around the macula that measures about a disc to a disc and a half in diameter, the central part of which is hypofluorescent. So from this, we can start thinking about what could cause this. ARMD with neovascularization, that's the wet form, and other causes. Now, what you have in this picture is a choroidal hemangioma. So this, the fundus photo, this is not so common in our environment. So this shows some vascularity within the tumor here. Now, it's from the choroid, so it gives a bumpy appearance of the overlying retinal tissue, and it could actually induce a serous retinal detachment. Okay. Now, look at the edges here. The phase we have here, look, okay, what we have here is this arterial phase. Just move from choroidal to arterial phase, choroidal and arterial phase. Although there's some form of laminar flow here. So now you see the edges. I told you that it could cause some form of serous erosion. So the edges are hypofluorescent. So something is masking the background hyperfluorescence of the choroid here around the edges. But the central part of the tumor is hyperfluorescent. At the same time, the choroid is hyperfluorescent. So it tells you the location. Okay. Now, if we come to the late film, late because the vessels have emptied out, the choroidal hyperfluorescence has diluted with time as well as the vessels, but you still have a hyperfluorescent here. So some of the dye is within the tumor. Okay, so it's a pulling and also it's a leak within the tumor. All right. So what we have here is central macular edema, cystoid macular edema with telangiectatic vessels. So look again that in the fundus photo, the macular reflectivity is not sharp, it's poor, it's dull. Okay. Now, the vessels are around the macula. The telangiectatic vessels are around the macula. Okay. So whatever caused the leak of fluid that caused this form of exudative subserous fluid and exudative ROD, it just tells you that the vessel is not just at telangiectatic, it's also leaking. So the dye from the vessels accumulates within the retinal layer and gives you this fine form of petaloid appearance. Okay, so this is a leakage, evidently. So at this time, you expect that this whole area should be dark. The retina should have emptied out, but you have leakages down here. There are also leakages. Okay. Now, the patient in this has branch retinal vein occlusion, inferior branch retinal vein occlusion. You would have some hemorrhages and then have some fluid around this area. Now, in the fundus angiogram, now guess the timing in your mind. That will tell you what's going on. The vessels are empty. They've emptied out. It's the late phase. Okay, just some stripping. Yeah. But you see this pattern hyperfluorescence here that is towards encroaching towards the macula. So the person had a branch retinal vein occlusion and you had leakages of dye from the tortuous vessel into the retinal tissue. Okay. Okay, now this is another aspect that we explained the other time. The dye could leak out of the vessel and then stain the vessel itself, making the vessel extra hyperfluorescent. That's what we call vascular staining. Okay. Now, this is a continuation from the branch retinal vein occlusion, actually. So, one of the key features to notice, see the background. This area is dark. So this area is hypofluorescent. So dark is the right time is hypofluorescent area. Some patchy hyperfluorescent area from the normal retina. So this is this aspect enlarged. So this area is normal. But this area is the area affected. So everything going on, capillary drop-off makes the area hypofluorescent in this patient at this time. Okay. Now, but the dye has left the intravascular space and stained the vessel itself. So the vessel is hyperfluorescent. The outside part of the vessel is hyperfluorescent. So it retains some dye. So this is a perivascular staining. The vessels themselves were stained. See this one here. See how shiny it is here. Is the dye. Compare this to this vessel here, or this vessel here. This is shiny. This is staining of the vessel itself. Okay, to our classic central serous chororetinopathy, which most of us know about. Now, this picture is depicting the pathology, okay? The RPE barrier has been abraded, and then you have serous fluid getting through across the RPE and is subretinal, okay? Subretinal. And you have this dome-shaped elevation of the retina around the macular area it's meant to be. So this is what you have here. So the reflectivity of the retina here is poor, and you have a dome-shaped appearance here, serous kind of appearance. Now, so the pulling is that the dye will leak into a potential space, abnormal potential space, or there are some areas of the retina. There are some areas of the retina, notably the outer plexiform layer, that could serve as potential spaces in the event of leakages. Okay. Now, what we describe in CSR is the ink blot and the small stack appearance. Now, if you understand the principle, you would know what's going on. So the dye leaks. So the question is, which phase is this? Really? This phase, if you look at the vessels, you have your retinal artery. This is the vein. The vein is beginning to have some laminar flow. The central part is empty. Okay. At this phase, you still have your background choroidal hyperfluorescence. So at this phase, you have an ink blot. It's a dot. That's to tell you, at this phase, during the choroidal phase, it seeps through the RPE defects. So it gives you the dots you have, because the break is tiny dots. But with time, through the angiography, more of the dye comes in. And as they come in, they seep into the potential space created and give something like, if you have a smokestack, the idea with the smokestack is that the pipe, which is this the pipe of the pipe of the chimney or whatever is thin, but the smoke coming out of it is air. So it comes out first and then it spreads out. So in this one, the dye has come out as a dot, then it's leaking into the potential space. So it's spreading out. Okay, so it's spreading out. So the ink blot first, then it's spreads out at the smokestack. Okay, so this is the CSR that would have. So which phase would this be? This is a recirculation phase in this eye, actually. This is empty. This is emptying out too. And some form of background hyperfluorescence. So it's recirculation. The dye is getting diluted with time. Okay, so it's towards the late phase. All right, so in this picture, we have a sub-RPE accumulation. So the RPE is intact. We have a sub-RPE accumulation, and you have the serous bump here. This is a form of retinal detachment involving the macula. So you have a serous ROD. Although the RP is intact, the bump lifts everything here. So the fluid is seeping here, and there's a bump here on the retina. And when you go to the angiograph, you look at this is arteriovenous phase, See this abnormal hyperfluorescence here centrally. And in the late phase, where everywhere has emptied out, you have hyperfluorescence. Now, there is something characteristic here that we should look out for. Now, this will tell you the level of what's going on. In this late phase, where's my question? Okay, in this late phase, look very well. You can see the vessels, empty vessels, well delineated above the hyperfluorescence. So it tells you the level where this is happening. Okay, if this was happening in the vitreous for any reason, you won't see these vessels. They will be blocked. Remember, we discussed last time. If it's happening in the nerve fiber layer, okay, in the vitreous, everything will be blocked. This hyperfluorescence would have passed over and you won't see the vessel below it. If it were from the nerve fiber layer, the big vessels and every other thing will be affected. Okay? If it was in the inner nuclear layer, the big vessels will be spared. Oh, excuse me. The large vessels, so the large vessels will be spared, and the smaller vessels and the arterioles will be affected. Okay? So, but this is happening at sub-RPE layer. So the vascular layers are spared. The hyperfluorescence you have is from beneath, it's from the choroid. Okay, this is sub-RPE fluid accumulation by exudation, pachychoroid complexes, where you have your thick choroid and leaky choroid as well, and have a sub-RPE elevation. Okay. Okay, so the idea with staining is that some tissues retain stain. They hold fast to stain, and in the late phase, they give out hyperfluorescence. So scars, scleral drusen. This patient has drusen all over the place. Now, one of the things we said about drusen is window defects when there's geographical atrophy. And you see that the drusens are not just large, they are also confluent. They are coming together. So a PED is a possibility when they exceed the size. So now this is a late phase. You see the same pattern you have here, it's the same pattern you have here. So the drusen has stained. So it's retaining dye. So it's vessel, the retinal vessel, say perivascular staining, and then the scleral tissue. This is typical of drusen. So I'll be glad to take questions and any clarifications. Thank you very much.
Thank you very much, Dr. Ume. It's been a wonderful morning listening to you. And right now, we'd like to pause and entertain questions, clarifications, or if anybody has any comments, you can please signify. I can't see any questions right now in any of the chats. Does anybody have any questions? Kindly signify. I guess it's well understood.
Yes, you did a good job.
Okay. Yes, thank you so much, Dr. Ume. So I'll ask again, does anybody have any question, or we can call it a good morning?
Thank you so much, Dr. Ume. Thank you for a beautiful presentation.
Okay.
Thank you.
Okay, Dr. Okoye Agnes, please, we can go ahead.
Thank you, Dr. Ume, for the wonderful presentation. It was really, really educating. Please, I want you to please clarify the difference between the angiogram of the scar and that of the drusen. I didn't get the explanation on how to differentiate the two. Thank you.
Okay, so for that angiogram of a scar and a drusen, the thing is, the first key to this is you've seen the patient in the clinic. You know what you saw on fundoscopy, and you did a fundus photo. So you are going to correlate your fundus photo to the FFA. If, for example, the picture right before us here, see where my arrows are. If instead of having drusen, I have a form of a retinal scar, and at the end of the day, I see a hyperfluorescence over it. I see a hyperfluorescent over it. It's clearly that the hyperfluorescent in the late phase or at the late phase, you know that this is a scar. So you don't know it just by saying, oh, the hyperfluorescent was like this, so it's a scar. It's stained. Okay, so what you take from it, you correlate the fundus photo to the angiogram. But if you don't have a fundus photo and you didn't see the patient, then you may want to say, okay, I want to see the patient. And anyways, scars are not, scars has patterns. Scars do not have patterns like drusen. Drusen will give you classical patterns of being dots, round, discrete, confluent, and all that, and around the macula, and then spread out from there. So you correlate your fundus photo to the angiogram.
Thank you, sir.
Thank you very much. I hope that's answered it. So someone said I should rattle this is, oh my God. Okay. So the phase this is just simple. The first phase is the choroidal. So some persons will say pre-arterial, but it's choroidal phase. Then you get to the arterial phase. Okay. So you transit from the arterial phase to the arterioles and the capillaries. From there, you get to the venous and then the veins. So this is just, it's a continuation. Don't think about it, just follow the sequence. Choroid comes in first, you transit, then your arteries start filling. Arteries move down to the arterioles and then to the capillaries, to the venous, then to the veins. Then you have a recirculation. That's how it goes, okay? Okay, so microaneurysm is a vascular dilatation, okay? A dot hemorrhage is a leak, is a bleed. So a microaneurysm would be hyperfluorescent. As the dye passes through the vessel, the area will give you a dot pattern in the area of the microaneurysm. But in a dot hemorrhage, the hemorrhage will rather block your background hyperfluorescence, depending on how large the hemorrhage is. So if it's so large a hemorrhage and it's happening at the inner nuclear layer, what it will block is the hyperfluorescence from the arterioles. Those are the vessels at that level. The arterioles, the capillaries, and then the choroidal hyperfluorescence. So that's for dot hemorrhage. Okay, so one is a hypofluorescent, one is a hyperfluorescent. So that's what makes the difference there. Okay. So, all right. So I think I've been able to go through all the questions. Thank you, guys. So let's keep operating. Yes.
Thank you so much, Dr. Ume, for this wonderful presentation. Part 1 and 2, very, very educating. Now, to everybody that has joined, we also like to thank you for being part of this clinical presentation, and we hope to always have you around. And I hope we've been able to have very clear information concerning abnormalities of fundus fluorescein angiography. Thank you all for being part of it. Enjoy the rest of your weekend. Thank you.
Thank you and goodbye.